Thank you very much for your introduction, Sunna. It seems you introduced me a lot in Korean language, but I'm gonna introduce myself as well too. And then at the beginning, I'd like to say hello, everyone. I am Shiho Kino. I'm an assistant professor at Tokyo Medical and Dental University. First of all, I'd like to thank Professor Sunna to invite me as a lecturer here at the Korean Society for Equity in Health. It is very nice to meet you all, and it was a great honor for me to give a lecture here. And I wish I could meet you all in Seoul in person though. And I met Professor Sunna at Harvard University when I was a postdoctoral researcher there. And at the time, we worked on several projects together, and I learned a lot from her. And she's a great teacher and a researcher, as well as one of my good friends, if I'm allowed to say that. And so I appreciate that she gave me an opportunity to talk to you all here. So, okay, now I'd like to start this lecture. And here is TMDU, which is a national university in Tokyo, where I graduated, and also currently I'm working. And these two are King's College London and Juntendo University, where I graduated. I got a master's degree. And then this is Harvard University, where I was working as a postdoctoral researcher and met Professor Sunna. And there are two universities, Tokyo University and Kyoto University, where I was working as a postdoctoral researcher too. And please let me introduce my background, as some of you might be interested in it. And this is my profile. I graduated from TMDU in 2009 and got the master's degree in 2011 at Juntendo University and at King's College London in 2017. Meanwhile, I was working as a research assistant in those universities and as a postdoctoral researcher at Harvard University, the University of Tokyo, and Kyoto University. And currently, I'm an assistant professor at TMDU. And probably it was difficult to know where I was from my profile, so I made this slide. I was born in Japan and lived until 2011 March, then went to the UK. And I lived there for almost 6 years and moved to the US in 2017. Then I was working there for almost 3 years. And finally, in 2020 April, I came back in Japan. As for my private life, I got married in 2019 and welcomed a beautiful baby boy in 2020. From now, I'd like to talk about today's research topic, health inequality and a social system. I try to speak slowly, but if it's not, please let me know, because sometimes I speak very fast. And please do not hesitate to interrupt me to ask questions, even during the lecture. And I welcome any questions, but I'd like to restrict to only 2 languages, Japanese or English, when you ask questions. I wish I could speak more languages though. Okay, then let's get started. First, I will talk about why I was motivated to research on health inequality. When I was a university student at TMDU, I studied oral health sciences to be a dental hygienist and social welfare to be a social worker. During the clinical training, I found that people with low-income people tended to have health risk behaviors, such as smoking, binge drinking, poor diet, and lack of exercise. On the other hand, rich people tend to have health-promoting behaviors, such as moderate exercise, balanced diet, and health checkups. At the time, I felt that wealth should not determine life or death. In addition, social welfare should play a role on it. Then I wanted to study more about health inequality. Then I studied health inequality. Before I studied, I thought individual health behaviors and quality of healthcare system could be the largest determinant of health. However, I learned socioeconomic factors account for 40% of determinants of health, in fact. Then, when I looked at the health inequalities between countries, the higher GDP per capita, the longer life expectancy. This is not only the case between countries. Even within Japan, there is a health inequality. The poorer the person, the higher the mortality rate. These studies motivated me to study how to reduce the socioeconomic inequality in health. Okay, from now, I will introduce some comparative studies between Japan and Korea, written with Professor Sunan. When we were at Harvard, Professor Sunan and I were chatting during lunchtime that neighboring countries, Japan and South Korea, had the world's longest life expectancy, but also the highest suicide rates. Then we wanted to know if we can observe the same determinants of mental health, especially related to poverty and physical health status. We found that poor physical health correlated with depressive symptoms among the older people in both Japan and Korea. However, income was associated with depressive symptoms only among Korean older adults, as you can see from this figure. We discussed that Japanese generous welfare system for the older people, such as pension scheme and long-term care insurance, might be related to the finding that health disparities in Japan were relatively smaller than in Korea. So the difference in social systems could attribute to health inequality. In this study, we compared the inequalities in self-rated health between Japan and Korea. In Japan, disparity in self-rated health was found to be relatively small on both absolute and relative scales, presenting in gray scales. In Korea, black lines, the absolute disparity in self-rated health assessed by SII was higher among middle-aged and older adults compared to other age groups, while the relative disparity in self-rated health assessed by RII was greater among younger adults. As we can see from this figure, the comparison makes the problem we should discuss clear. In this study, we performed the age period cohort analysis using WHO open data on suicide from 1986 to 2015 for Korea and Japan. Using this analysis, we could see the effect of age, period, and cohort separately like this. Suicide increased rapidly around retirement age in Korea, but not in Japan. And suicide increased rapidly during the last 30 years of observation in Korea, but remained almost stable in Japan. And Japan shows a U shape, indicating the post-war generation in Japan had a lower suicide rate than those born before 1916 or after 1961. While in Korea, the suicide rate increased linearly for each generation. Thus, the trends on suicide in Korea, the black line, and Japan, the gray line, are considerably different. From the findings, we reported that the underlying causes of the suicide trends are different between Japan and Korea. From these comparative studies, we can see that the different environments, including social systems, could play an important role on health. From the previous studies, we learned that health is quite influenced by society and systems. This can be explained by this famous picture, although I believe most of you already know it. When there is a river like this, downstream approach indicates chronic disease treatment, while upstream approach addressing social determinants of health, such as conditions in which people are born, grow, live, work, and play. And public health works upstream to promote and protect health and prevent people from becoming sick. So I wanted to know what kind of social systems which could impact on social determinants of health could be beneficial on health inequalities. Then I studied the role a country can play in addressing health inequalities. For that purpose, I needed different systems in different countries, but the same data at the individual level in every country. In EU, they do have this kind of rich data, so I examined the impact of healthcare and education on health inequalities. First, I used the data from 27 European countries of Eurobarometer and conducted latent class analysis to identify clusters according to the patterns of 5 health behaviors, including 2 risk behaviors, smoking and alcohol consumption, and 3 promoting behaviors, such as fruit consumption, physical activity, and dental checkups. Latent class analysis suggested 3 clusters. The red one includes more risk behaviors, such as high rates of smoking and alcohol consumption, and the green line includes more healthy behaviors, such as fruit consumption, physical activity, and dental checkups. The blue line includes moderate proportions of each behavior. Therefore, I named the red one is a risky cluster, and the green one is a healthy cluster, and the blue one is a moderate cluster. Then I examined the relationship between these groups and socioeconomic factors. From the analysis, I confirmed that there were socioeconomic inequalities in those clusters. In this study, impact of country-level factors on the individual level health behaviors is analyzed using a multi-level analysis. I found that higher expenditure on health are better the quality of healthcare system at the country level, the lower individual health risk behavior. However, this association was not observed when adjusting for individual socioeconomic status. To sum up, there was a socioeconomic inequality in health behaviors, and I found that the better healthcare and education system seemed to be related to better health behaviors. However, the socioeconomic inequalities in health were not reduced, even if these systems are really well. I thought the reason for this would be that in most European countries, education and healthcare systems is free to everybody. This means that healthcare and education systems in EU were equally distributed. Therefore, it could bottom up the population health, but might not contribute to the inequality. Then I was thinking of what about focusing on risk population? In Japan, there is a public assistance system, and I'm sure there isn't a similar system in South Korea, or people who do not have a minimum financial level are entitled to public assistance. The recipients of public assistance can get monthly income benefits and are exempt from healthcare and dental care. So I hypothesized that they might face fewer financial barriers to receiving healthcare and be healthier than non-recipients. In this study, we examined whether welfare recipients were more likely to have depressive symptoms or not, using J-AGES, which is the Japanese national-wide cohort. We found that older welfare recipients were found to be 1.6 times here, more likely to have depressive symptoms than non-recipients. And social participation, such as meeting friends, a number of friends, participation in sports clubs and hobby clubs, may slightly attenuate the negative relationship between them, but recipients still are related to having more mental health problems. We also tested using a propensity score matching as a sensitivity analysis, which means that we matched the conditions between recipients and non-recipients and created the identical population in terms of conditions such as income, medical conditions, and household number, except for receiving public assistance or not. Then we compared between those identical groups. We found the same findings as the main analysis. So we have reported that welfare systems need to consider including mental health care support in addition to financial support. As I said, welfare recipients are fully exempt from having to pay for dental care. So we aim to examine if wealth-related inequality was eliminated among all the adults in Japan. However, we found that wealth-related inequality persisted among all the people in Japan. And welfare recipients are 1.7 times more likely to have unmet dental care needs compared to those with the highest wealth. And we could observe the clear gradient. Through these studies, we found that the recipients of public assistance have worse health and have more unmet dental needs than non-recipients after considering socioeconomic factors. Thus, the welfare system could work as a safety net, but it might not contribute to reducing health inequality. Can you think of the reason? I discussed that this might be because health inequality is deep-rooted and it is not easy to be addressed. In addition, the welfare recipients are stigmatized, and the stigma and related stress might prevent them from accessing health care. I think some of you might have noticed that the examples I used could be applied to two famous public health approaches. The example of a European healthcare system could be applied to the population approach proposed by Jeffrey Ross in 1985, that it targets the whole population regardless of variations in individuals' risk status. If we draw the percentage of the population on the level of risk for certain outcomes, we would see this normal distribution. Here the horizontal means the level of risk, and the vertical line means the percentage of population. The middle part is a normal risk, and the left tail is a lower risk, and then the right tail is a high risk population. This strategy encourages everyone to change and try to shift the entire distribution so that we can reduce the total number of sick people. On the other hand, the public assistance system could be a high-risk approach, which targets individuals identified as an elevated risk for adverse outcomes and try to move high-risk individuals into normal range. From my previous studies, both approaches are beneficial to the population health, but it seems not to contribute to reducing health inequality. To sum up, population approach could bottom up the whole population, but might not reduce socioeconomic inequality. High-risk approach could work as a safety net, but it might not contribute to reducing socioeconomic inequality. Then what about proportionate universities? It was introduced in 2010 by Sir Michael Marmot in Fair Society Healthy Lives, as known as the Michael Marmot Review. He says in this review that focusing solely on the most disadvantaged will not reduce health inequalities sufficiently. To reduce the steepness of the social gradient in health, action must be universal, but with a scale and intensity that is proportionate to the level of disadvantage. We call this proportionate universalism. So proportionate universalism might be the most beneficial approach to health inequality. So here I would like to emphasize that I do not say population approach and high risk approach are not beneficial. Actually, they are beneficial to the population. For example, water fluoridation, which is a population approach, contributes to reducing inequality in dental caries. But I would say in terms of reducing inequality, proportionate universalism is the most beneficial. And can you think of an example of proportionate universalism? I was thinking of Affordable Care Act, as known as Obamacare, which was officially implemented in 2014 in the United States. And what it does is to support the low middle income people to have health insurance proportionately. Consequently, a whole population have health insurance. So I examined if Obamacare could reduce socioeconomic inequality in health or not. Each state in the US can choose if they adopt Obamacare or not. So we can dichotomize the 50 US states into ACA Medicaid expansion states and non-expansion states. Using the behavioral risk factor surveillance systems in the US, the changes in inequalities are analyzed using a difference in difference analysis. And SII is a slope index of inequality, indicating absolute inequality, and RII is a relative index of inequality, indicating relative inequality. As you can see from these figures, since 2014, socioeconomic inequality measured by SII and RII reduced in Medicaid expansion states compared to non-expansion states. From these results, I confirmed that this approach could reduce socioeconomic inequalities in experience of not being able to see a doctor for financial reasons, having a family doctor, and reducing regular medical checkups. On the other hand, there was no impact on inequalities in preventive examinations, suggesting that implementation of ACA expansion may have been insufficient to correct inequalities in preventive examination. A little bit going off track, but from the previous study, I was thinking why inequalities in necessary visits were reduced, but not in preventive visits. Then I wanted to examine the influence of health literacy. In this study, I examined whether lack of health literacy prevents from seeing a doctor even if they have insurance. As a result, health literacy did not explain why did not see preventive health services even if they had access to health insurance. However, only for dental visits, we found that people with higher health literacy increased their visits after obtaining health insurance. In this study, I employed two-stage least squares instrumental variable analysis to examine the spillover effect of Obamacare using BRFSS, which is a famous US study. Which means that I examined if people obtaining health insurance stemming from ACA expansion, the stress related to paying diet and rent reduced or not. We found that having health insurance may have increased the disposable income among low-income individuals. Thus, this approach brought spillover benefit to the population. Okay, let's get back on the track to make a summary. By the way, can you explain the difference between equality and equity? Equality approach means each individual or group of people is given the same resources or opportunities. Equity here means that each person has different circumstances and allocates the exact resources and opportunities needed to reach an equal outcome. So I always use an example of pizza to explain the difference between them. Imagine there is a big pizza and then there are two people. I would divide the pizza into two people, and then if I make it into half, this is equality. But one person is not very hungry because he just had a had a big lunch, and then other person was really hungry because she skipped lunch. Then I would give a big proportion to the hungry woman and a small portion to the full man. This is equity. And this is a Korean society of equity in health. So you should aim equity like this, I think. And proportionate universalism is a combination of these two, meaning reduced resourcing delivering of universal services at a scale and intensity proportionate to the degree of need. So my take-home message today is that proportionate universalism might be the best option for health equity. Are there any policies or measures using proportionate universalism surrounding you? And if there are not many, why don't you suggest them? You could be a mom or dad of health equity in South Korea. So this is the end of my lecture. Thank you very much for your listening. And now I'm happy to answer your questions or listen to your comments if you have. Thank you very much.
Thank you for your great presentation, Dr. Kino. 질의응답 시간인데요. Is there any question? If you have question, you can use chat room. 채팅방에 남겨주시거나 아니면 just raise your hands or turn on your microphone and ask a question.
Yeah, sure. Or like if you have questions in Korean language, then like in Sundan will translate it to English. So don't hesitate.
Okay.
Yeah.
I will do my best.
Yes, please.
네, 뭐 이제 질의응답 시간인데요. 여러분들 질문 있거나 뭐 어떤 질문도 좋을 것 같아요. 뭐 연구 커리어에 대해서도 좋고 아니면 그 일본에 있는 다양한 뭐 대학에서의 건강 불평등 연구 현황이나 뭐 이런 질문도 좋고 네, 좋습니다.
Is there any, I'm sorry, I do have questions to you guys actually. Yeah. Is there any examples of a proportionate universalism in South Korea?
universal. 네, 그러니까 보편 비례주의적 방식으로 접근하는 프로그램이 있냐는 질문인데 한국에 mostly in the social services in Korea try to adopt universal, proportionate universalism, maybe, but very limited. Yeah. Most of the social services and medical healthcare services are focusing on the vulnerable population. We have criteria and then focusing to the most vulnerable population to give services like medical aid and other social services. But we also try and have many plans to adopt that universal, proportionate universalism. I'm sorry.
It's hard to say. Yeah. Thank you. because in Japan there are not many actually, and probably I think I think probably you have it in South Korea too. Like there is we say hello baby program. So like if you have a baby, newborn baby within a month, then the public health nurse visits the house, visiting the actual household, and then say hello, and then it seems just like saying hello, but like if the nurse notices like she might have depression or she might need more care, then like she provide more. But like just checking, because like there is some like how it's called, like maternity depression. So there are a lot, and then actually after they do, the depression decreased, and then death of small babies decreased. So that's why it was actually beneficial.
I think that just exact same program in Korea. We started that pilot program a few years ago. Yes. But the name is different. The project name is different, but yeah, we have that too.
Similar one, yeah. Yeah, I feel like in February it was succeed in other countries, so that's why like people, I mean, in other countries try to adopt it, I guess.
Yes, right. Yeah, Australia and UK. Yeah. They have that program named Family Nurse Partnership Program.
I see.
So yeah, we have
also
that.
Do that.
But it's still pilot stage.
Yeah. So not everybody now. Then.
Not everybody.
I see.
질문 있으실까요? 많이 조용하시네요. I have a question to you.
Sure.
When you do international comparison study, you may be criticized for not having enough data to verify different social system as you focused on. So do you have any experience that critics from the reviewers or other collaborators, and how can you deal with that?
Okay, thank you very much for your question. Do you mean about the multi-level analysis? I guess, right? Yeah. So actually, I asked about this Subramanian. He is a god of multi-level analysis about it, and actually, I got a lot of criticism on it. Yeah. So I mean, to the student listeners, I would say that like so. I use 27 European countries, but the multi-level analysis, higher level should have after a lot of numbers. So like some people say more than 50, and some people say more than 30, and some people say 100, but actually there is no gold standard so far. And then, but I think people say around 30 is the minimum. And if it's less than that, the statistical power is quite low. So some people criticize it, like if I can do this analysis or not. But I asked Subramanian, and he said, and he's, as I said, he's a god of multi-level analysis. And he said he would do that, even though if he has only 5 for the higher level. And we cannot increase the number of European countries. So that's why like we cannot control it. Like if he can increase the number, like to recruiting more people or like more cities, probably we can change it, but we cannot change the number of European countries. So that's why you cannot change it. So that is the answer. So I conducted, and Sub said he does it anyway. And then if he gets the strange result, he will consider it. But if it seems okay, I think it works, he said. So I used it, and I published the paper. Thank you very much for your question.
네, 혹시 질문 있으실까요?
Can I ask one question?
Sure.
Thank you for your good lecture. especially your introduction was very interesting. I am wonder, how did you start your study? I mean, you are focusing on health inequality, but your background is not social or so why you start to study health inequality?
Yeah, thank you very much for your question. Yeah. And I would say, yes, as you said, like in my background is a dental hygienist and a social worker. And then I need to do clinical training at my bachelor degree in the university. And then I saw several patients. And then I found it was a national university, so there are a variety of patients. And I found rich people tend to have better oral health. And then like poor people, like we can see from the insurance status, and then poor people tend to have like bad teeth oral health status. And then I thought that like it's not right. It's just unfair. Like rich people have better health and the poor people have bad health. This is just unfair. We should be, everybody has a healthy life. And then, as I said, I was also studying social welfare to be a social worker. And then I wanted to do something from the social view. And then I was studying social welfare, so we might be able to do something to the poor people to have the same status as the rich people. So this is actually what I'm motivated to do health inequality. And then this is the reason why I was always focusing on the social systems on health inequality. Yeah. Could I answer your question? Yeah, thank you. Thank you.
Yeah, I understand that question because one of the main issue of our Korean academia is that how can we motivate to study and research about health inequality to more scholars, more students. So
Sure.
that is the reason why we open this kind of seminar.
Great.
Yeah, so most of the audience is young scholars, excluding some of professors. I can see the senior professors in here, but mostly, yes, young scholars. So your career and your try and error of the research about the international comparison on the social systems and your courageous moving to another country to study more and more and make a friendship with other big scholars in other countries. That would be a great example to motivate our study and research on health inequality.
Thank you very much. Thank you very much for your comment.
네. 혹시 또 질문 있으실까요? 하나만. 네. 네.
Hi, I'm a student. I'm a course of a master's degree in SNU in health equality. And what do you think is the possible and realistic solution to health equality in a country like United States that have not universal healthcare system? Because the Obama just tried to just expand the Medicare, Medicaid like that through ACA, but just because of due to the path dependent nature, it is hard to just build a new system. But they just decided to expand the Medicare and Medicaid, and so what do you think is the realistic and possible way to in the country to magnify the health equity?
Thank you very much for your comment. If I understand you correctly, like, and so there, they do Obamacare, but some people adopt Obamacare. Some states adopt Obamacare, but some states don't. So that's why. So how do we approach to the whole nation? Do you mean?
Yeah,
Did I understand correctly? Yeah.
Yeah, in a situation that just because they didn't have universal health care system before, so just they cannot build the whole new system, but just they fixed it. So just how can we do that?
Yeah, that is a very difficult question. Actually, a very good question. But I mean, the people in the United States want to be independent. They don't want to be told by the states or by the nations or something like that. So that's why, like, there is a huge argument when the Obama was president, and then President Obama wanted to do to whole nation, but actually some states said no, they don't want to. And then, so that's why it was a very good research natural experiment. So we can compare between the expansion states and the non-expansion states. But as you said, like, you know, the people in non-expansion states cannot get the benefit from it. So that's why I think this is it's an issue in the United States, and we should approach it. But they do have the decision. I mean, they decide. We cannot decide. We can suggest it, like, this is good, so you should do this, but they can choose. So as a public health researcher, we can show the evidence, this is good and this is beneficial, but we cannot force them to do that. So it is a difficulty as a researcher, but what I think what we can do is just showing the evidence, and then they try to change their minds, like, you know, we should adapt this. Sorry, my answer might not be very good, but I hope you could get my point. Could I answer your question?
Yeah, mostly because I asked you because I understand your answers, because I submitted 20 pages of report to my professor in this semester about USA, but there must be blind spots if there is no universal health care. So just I'm really concerned about it, and just wanna just talk about you and other colleges about it.
Yeah, I think universal health care is very important for the in the view of health inequality. And then actually, I think it's a very hot topic, isn't it? Like, all countries are focusing on a universal health care, and then, like, you know, we actually, like, in health researcher, think universal health care is really good, but some people might not think like that. You know, we don't have to pay for health. We just want to be happy, whatever. So yeah, we cannot change people's mind, like, but we might be able to change their mind if we show the good evidence. Sorry, what we can say, what I can say is now only that. Sorry, maybe probably I think it's a job to reduce the inequality in the US. Good luck.
네, 감사합니다. 네. There is one question, actually two questions in the chat room. Can you read that?
Yes, I'm reading right now. Sorry,
your SSM paper, maybe APC analysis about the suicide rate. It's really fun. However, as I tried to conduct a similar study, I feel that the meaning of the cohort effect is somewhat unclear when analyzing social phenomena such as suicide as a result. The generation who went through the Korean War clearly seems to have something to call the cohort effect, but the rest are unlikely.
introduce experience research using it. Yeah. I think it's better to talk in Korean languages now, or it's better for me to. Can I share the slide? Sorry.
Yes. 제가 이제 같이 공저로 했던 연구라서 좀 말씀을 드려볼 수 있을 것 같아요. 이 연구에서는 이제 WHO의 그 suicide rate를 이제 30년간의 데이터를 가지고 APC 분석을 한 건데, 그러니까 그 코호트 이펙트가 있다라는 거 정도는 확인할 수 있지만 그게 어떤 코호트 특성을 가졌는가에 대한 해석은 이제 연구자의 몫이었던 것 같고요. 이제 그런 측면에서 이제 그 한국의 뭐 코호트, 그러니까 1951년생에 비해서 1932년생들 예를 들어서 이제 32년생들이 어떤 정도의 뭐 자살을 보이는가에 대한 상대적인 리스크를 받기 때문에 그런 측면에서 이제 결과를 해석할 때에는 사실상 코호트 이펙트라고 이야기할 만한 것은 발견되지 않았다라는 거고, 그러니까 코리안 워를 언제 겪었는가에 따라서, 그러니까 청년기에 겪었을 수도 있고 청소년기에 겪었을 수도 있는데 그런 거에 따라서 이제 코리안 워 코호트라고 할 만한 것들을 도려내기에는 이 분석 자체는 어려웠다. 이제 그렇게 포커싱한 것이 아니었기 때문에, 그래서 말씀하신 대로 이제 그런 정도의 코호트 이펙트를 조금 더 확인하자면은 그에 상응하는 이제 리서치 퀘스천을 가지고 좀 더 파고들어 분석할 필요가 있다라는 것이고, 사실 이게 이제 그러니까 일본과 한국의 이제 노인 자살률을 어떻게 해석해야 되고 왜 이런 양상이 발견되는가에 대한 이제 질문에서부터 시작된 연구였기 때문에, 일본은 어느 2010년대 후반부터인가 하여튼 노인의 자살 사망률이 이제 쭉쭉 떨어지는 양상들을 보여서 이게 도대체 왜 이렇게 떨어지나를 이제 보기 위해서 봤더니 일본은 코호트 이펙트였다라는 거고, 이제 그림에서 나타났다시피 일본의 지금 현재 중년들의 이제 51년대생부터 61년대생까지의 중년들의 코호트에 비해서 30년대생, 20년대생, 10년대생들이 그 당시에 이제 훨씬 더 많은 자살률을 보였고, 그 코호트들이 대거 이제 인구 집단에서 사라지면서 노인의 자살 사망률이 이제 쑥쑥 떨어지는 양상을 보인 게 아니냐. 결국 어떤 뭐 소셜 시스템이나 어떤 팔러시나 뭐 노력에 의해서 줄어들었다기보다는 그런 코호트 이펙트였을 가능성이 있음을 문제 제기하는 것이고, 그런 측면에서 이제 한국의 그 노인의 자살 사망률을 다시 한번 이제 같이 대비해서 이제 본 거거든요. 이제 그런 측면으로 좀 이해해 주시면 어떨까 싶어요. 이 연구가 되게 여러 측면에서 여러 의견들을 저도 많이 들었어가지고 지난 2년간 아마 저도 많은 해석과 이제 이야기들을 한 것 같습니다. 네, 답이 되셨나 모르겠어요. 말씀하신 코리안 워 코호트 이펙트에 대해서는 분명히 해볼 만한 연구라고 생각이 듭니다. Another question from Dr. Liu. Not doctor, student. 네.
Thank you very much for the answer. And
yes,
the,
yes.
The student,
네.
the person who asked the question, did you get it?
Yes, another question is about. Thank you for the such. 네, 답변이 되셨나 모르겠습니다. 일단 다음 그 질문으로 넘어갈게요. Thank you for such a great lecture today.
I read it. Yeah.
Can you answer?
Yeah, sure. Yeah, and so a small question in mind is an economical perspective. Wouldn't it be more cost efficient to take selectivism rather than pure and proportionate universalism when considering welfare policy? Yes, that is completely right. Yeah, the risk approach is more cost effective because we can select the people and then we just approach them. But however, cost effective, yes, but from the result, to reduce inequality, it is good to approach everybody as well, and then also it should be more approach them proportionately. That is more beneficial, but as a cost economic perspective, you are right. This population is much more effective because we just target them. Yeah, you are right. Yeah. And then second question, a third one. Sorry.
COVID-19. Yep. Thank you for giving me a great lecture. I'm interested in comparing Japan and Korea's policies about COVID-19. As you may know, the outcome of COVID-19 in Japan is relatively lower than other countries. So I would ask if the outcome is affected by Japan's policy about COVID-19 related to equity.
It is a very difficult question, and actually I'm not very working on COVID-19 project. So like, well, but in general opinion, as a Japanese, I'm not sure like Japanese policy is actually the best. I mean, we still have a lot of problems as well. And then, but about equity, equity, related to equity, well,
is there any equity issue in Japan you have heard from the mass media or other inside Japanese scholars? So do you have any experience?
Well, like yes. So about the inequality, the COVID-19 increase inequality, actually, because like in the poor people lose more jobs, and then like they also have to survive about the health problems because they don't have money. So, but like what we do about, sorry, the inequity perspective, we try to give the shot, the vaccination earlier for people who have more severe disease, for example, and then they might tend to have they might be more disadvantaged people because like they have more health problems. And also we do have some we do give them for the benefit, like some money actually, but it's not a lot, so I'm not sure like it helped or not. And actually like in the Japanese government distributed the money to everybody, so I'm not sure this is good or not. Like some people say we should give more money to poor people, but like everybody gets the same amount. So I'm not sure this is good for equity or not, but at least some people could get some benefits from the government. So still we have to discuss and we have to examine the effects of the benefits, but still going on. And then I think it's coming later probably. And also I think in this situation, the country comparisons are very good because like we do have different policies, so like we can compare the policy effects. So I think it's your job to examine. Yeah.
Okay, so later, can you share the Japanese research or studies about the health equity in COVID-19 later? Yeah. Not today, but later, if you
sure.
have any. Yes.
Yeah.
Great.
Sure.
Yeah. We
sure,
can
definitely
have more chance to invite you.
Sure. Thank you.
Thank you very much for your great speech, and thank you also your sincere answer to many questions.
Yeah, it was
very
very
variety range of questions.
Well,
Can you give a big applause to Dr. Shiho Kino, everybody? 네, 감사합니다. 네,
Thank you very much.
고맙습니다.
감사합니다. Thank you.